Welcome back to Bookfulness, the Deep Dive, where we really get into the details of anatomical texts. Today it's clinically oriented anatomy. We're picking up where we left off, moving past the upper GI tract. This is episode 19. Today our focus is continuing that journey through the abdomen. We'll be looking closely at the large intestine and then those important accessory organs, the spleen and the pancreas, and of course tying it all back to the clinic using pages 801 through 834 from the text.
That's the plan. We're not just listing parts today. We want to pull out the really crucial bits, the anatomy that directly explains the pathology. Things like, why some parts are fixed and others move, the big vascular shifts, the tricky spot the pancreas is in, all aimed at giving you a clear, practical understanding for when you see patients. Structure, but always with that clinical why in mind.
Okay, let's dive right in then. Part 1. The large intestine. You said we need to move beyond just identifying it. So imagine we're in the OR, abdomen's open. What are the, say, top 3 things that scream, this is large intestine, definitely not small intestine?
Right. That's exactly the practical distinction you need. There are 3 really clear, gross anatomical features you'll see immediately. These are the hallmarks. First off, you've got the Taeniae coli. Now, this is a big difference from the rest of the gut tube. Usually you have that smooth outer muscle layer, right, the muscularis externa, but the large intestine does something different. It bundles up that longitudinal muscle layer into 3 distinct, quite thick bands. Think of them like stripes running down the length of the colon.
3 distinct bands.
Yeah.
Okay, and these are muscle bands, you said?
Yes, smooth muscle. Thicker than the typical layer you'd find elsewhere.
So if these Taeniae coli run the whole length, why doesn't the colon just look smooth with 3 stripes?
Yeah.
How do these bands create that sort of bumpy, segmented look we always see in diagrams?
Good question. That brings us straight to the second feature,
Okay.
the haustra. The key is that the Taeniae coli are actually shorter than the tube itself. Yeah, slightly shorter than the actual length of the rest of the intestinal wall they're attached to. So because they're shorter, they kind of pull on the wall like drawstrings. And that gathering, that puckering effect creates these sacculations or pouches. Those are the haustra.
I see. So the tension from the shorter muscle bands pulls the longer wall into these little sacs.
Exactly. It gives it that characteristic segmented look. And it's not just for show. The way these Taeniae contract helps churn the contents slowly, which is perfect for the large intestine's main job, absorbing water. It's all about slow transit here.
Okay, so we've got the bands Taeniae coli and the pouches they create, haustra. What's the third distinguishing feature? You mentioned one that sounds a bit like decoration.
Right, the omental appendices, or sometimes called epiploic appendages.
Look.
These are little fatty tags. They're projections of peritoneum filled with fat just dangling off the outer surface.
Fatty tags, do they do anything important?
Functionally, not really. No essential role that we know of. But visually, they're unique to the large intestine. So if you see the 3 muscle bands, the haustra, and these little fatty blobs hanging off, you're absolutely certain you're looking at the colon. Clinically, though, they can sometimes twist on themselves, cutting off their blood supply. That causes infarction and localized pain, which can, mimic other things like appendicitis or diverticulitis. So they matter for differential diagnosis.
Good point. Okay, let's follow the path now, starting right at the beginning where the small intestine ends. Talk us through the cecum and its rather famous little attachment, the appendix.
The cecum is the very first part. It's like a blind pouch hanging down below the ileocecal valve. That's where the ileum, the last part of the small intestine, empties in. It sits down in the right iliac fossa, that lower right part of the abdomen. Anatomically, it's the widest part of the large intestine. And importantly, the cecum is usually completely intraperitoneal.
Intraperitoneal, meaning it's covered in peritoneum and has some mobility.
Exactly. It often has a mesentery, though sometimes it's short, which allows it to move around a bit within that fossa.
And attached to this mobile cecum is the appendix. Tiny structure, huge clinical significance. What's key about its anatomy?
Well, technically, it's an intestinal diverticulum, just a little outpouching. But what's special is that it's packed with lymphoid tissue. It's really part of the immune system in a way. Now, the base of the appendix, where it attaches to the cecum, is the one reliable landmark. Remember those 3 Taeniae coli bands we talked about?
Yeah, the muscle stripes.
If you follow them downwards on the cecum, they all converge right at the base of the appendix. It's like they point directly to it. So if a surgeon is having trouble finding the appendix because it's hidden, they can just follow those Taeniae right to its root.
That's a neat surgical trick. But you said the base is fixed, yet the appendix itself is known for being in different positions. We always hear about the McBurney point. Can you explain that and why the appendix's location varies so much?
Right. The McBurney point is the surface landmark. It's about a third of the way along a line drawn from the pointy part of your right hip bone, the ASIS, anterior superior iliac spine, towards your umbilicus, your belly button.
Okay, 1/3 of the way along that diagonal line.
Yes, and typically the base of the appendix lies deep to that point. But that's just the base. The tip of the appendix can point in all sorts of directions. The book mentions, and figure 5.53 shows this well, that the most common position is retrocecal, tucked up behind the cecum. But in about 32% of people, it actually hangs down inferiorly, maybe even dipping over the edge of the pelvis.
Wow, so nearly a third of the time it's dangling down low.
Yeah. And this variability is exactly why diagnosing appendicitis can be tricky. If it's retrocecal, the inflammation irritates structures in the back, maybe causing flank pain. If it's down in the pelvis, it might irritate the bladder or rectum, leading to urinary symptoms or, feeling like you need to defecate. Completely different presentation based purely on where that little tip happens to be sitting.
That really highlights why a good physical exam, looking for those specific signs, is so critical. Okay, so from the cecum, the colon starts its journey upwards. Let's trace that path. Ascending, transverse, descending, sigmoid, and crucially, as you mentioned, which parts are fixed versus mobile. Talk us through the peritoneal status.
Okay, so leaving the mobile cecum, we head up with the ascending colon. This runs superiorly on the right side, up towards the liver, where it makes a turn the right colic or hepatic flexure. Now, the ascending colon is classified as secondarily retroperitoneal.
Secondarily retroperitoneal. Okay, pause there. That term sounds important. What does secondarily mean compared to, say, the kidneys, which are just retroperitoneal? What's the difference embryologically and clinically?
Great question. That distinction is key. Secondarily means that during development, when the gut tube was rotating and settling into place, this part did initially have a mesentery suspending it within the abdominal cavity. It was intraperitoneal for a time.
Ah, so it started out mobile.
Yes. But then its mesentery fused with the posterior abdominal wall peritoneum, effectively sticking the colon to the back wall. So it became retroperitoneal. Primary retroperitoneal organs like the kidneys or the aorta were basically behind the peritoneum from the start. They never had that mesentery stage.
And clinically, why does that matter? Does it change how disease behaves there?
It does. Being fixed means the ascending colon is less likely to twist on itself. You don't typically see volvulus here. But the downside is, if a cancer develops in the ascending colon, because it's plastered against the back wall, the tumor can more easily invade structures directly behind it, like the right kidney, the ureter, the psoas muscle, the quadratus lumborum. There's no mobile mesentery creating a potential space or barrier.
Okay, so fixed on the right side, then it takes that turn under the liver, the hepatic flexure, and heads across the abdomen. What about the transverse colon?
The transverse colon is completely different. After the right colic flexure, it becomes fully intraperitoneal again. It's suspended by a large floppy mesentery called the transverse mesocolon.
Meaning it's mobile.
Very mobile. It's the longest and most mobile part of the large intestine. Because it hangs on this mesentery, its position can vary hugely. The book notes, particularly in tall, thin people, it can dip way down, sometimes even below the level of the hip bones, the iliac crest. You have to be aware of that variability on imaging.
Then it reaches the left side and has to make another turn downwards. This one, the splenic flexure, often seems more acute, sharper.
It usually is. That's the left colic flexure or splenic flexure because it's right up near the spleen. It tends to be higher up than the right flexure. The angle is typically sharper and it's much less mobile.
Why is it less mobile? Is it stuck to something?
Yes. It's anchored quite firmly to the diaphragm by a fold of peritoneum called the phrenicocholic ligament. That ligament holds it up and limits its movement significantly.
Okay, so after navigating that sharp, fixed turn, the colon heads down. The descending colon, is it fixed like the ascending?
Yes, exactly the same situation. The descending colon is also secondarily retroperitoneal. It runs down the left flank, fixed to the posterior abdominal wall, with peritoneum just covering its front and sides.
So mostly fixed, though the text mentions some people might have a bit of a mesentery here.
That's right. About a third of individuals might have a short mesentery associated with the descending colon, giving it slightly more mobility than the ascending. But functionally, for clinical purposes, we generally consider it fixed and retroperitoneal.
And finally, before it straightens out into the rectum, we get that characteristic S-shaped loop in the lower left abdomen, the part known for getting twisted.
That's the sigmoid colon. It gets its name from the Greek letter sigma, S. It's a very mobile S-shaped loop that leads down into the pelvis to become the rectum.
And why is it so mobile compared to the descending colon just above it?
Because it regains a full mesentery, the sigmoid mesocolon. And this mesentery is often quite long and allows the sigmoid loop to swing around quite freely in the lower abdomen and pelvis.
Which I imagine sets it up for potential problems.
Yeah. Precisely. That very mobility makes it the most common site for volvulus, where the loop twists around its own mesentery, cutting off blood supply. We'll definitely come back to that in the clinical section.
Okay, fantastic tour of the path and its fixation. Before we leave the large intestine itself, we absolutely have to talk blood supply. You mentioned vascular transitions earlier. This is a huge concept, right? Especially for surgery and things like ischemia. Where's the big dividing line?
This is fundamentally important. The blood supply pattern reflects the embryological origins of the gut, the difference between the midgut and the hindgut. And knowing where that transition happens is critical. So basically everything on the right side of the large intestine, that includes the cecum, appendix, the ascending colon, and about the first 2/3 of the transverse colon, all of that is derived from the embryonic midgut.
And the blood supply follows that origin.
Exactly. It's all supplied by branches of the superior mesenteric artery, the SMA, specifically the iliacolic artery, the right colic artery, and the middle colic artery.
Okay, SMA for the right side and most of the transverse. What about the rest? The left side?
The left side meaning the last third or so of the transverse colon, the descending colon, the sigmoid colon, and the upper rectum. These parts come from the embryonic hindgut.
And they get their blood from a different major vessel.
Yes. They're supplied by branches of the inferior mesenteric artery, the IMA, that's the left colic artery, the sigmoid arteries, and the superior rectal artery.
So the big switchover happens somewhere around the end of the transverse colon, or the beginning of the descending colon, near that splenic flexure area.
Precisely. The transition point where the territory supplied by the SMA meets the territory supplied by the IMA is typically located near the left colic flexure.
And you mentioned this area can be vulnerable. Why is that specific meeting point anatomically risky?
Well, the branches from the SMA and IMA do connect. They form little communicating loops along the inner border of the colon, creating what's called the marginal artery of Drummond. This acts like a backup pathway, providing collateral circulation.
So there is some redundancy.
There is, yes. But the connection tends to be weakest right at that transition zone near the splenic flexure, where the final branches of the middle colic artery from SMA meet the branches of the left colic artery from IMA.
Weakest connection, so less backup.
Exactly. This area is often referred to as a vascular watershed area. Think of it like the very end of two different water pipe systems. The pressure and flow might be lowest right where they meet.
Okay, I can picture that, like the furthest point from both pumps.
Right. So in a normal, healthy person, it's usually fine. But if someone experiences a significant drop in blood pressure, maybe due to shock, severe bleeding, heart failure, or even widespread atherosclerosis clogging up the main arteries, this watershed area is the first part of the colon to suffer.
Because it has the most tenuous blood supply.
Correct. It's the most vulnerable spot for ischemia, lack of blood flow. This can lead to ischemic colitis, where that specific segment of the colon gets damaged or dies due to oxygen deprivation. Knowing that watershed location is key to diagnosing and managing those conditions.
That makes perfect sense. Okay, a really solid foundation for the large intestine. Let's shift gears now to those accessory organs tucked away. The spleen and the pancreas. Starting with the spleen, you called it fragile despite being hidden away?
Yes, the spleen. It's primarily a lymphatic organ, the largest one in the body, actually, and its location is key to understanding its vulnerability. It sits way up high in the left hypochondrium. That's the upper left quadrant of the abdomen, tucked under the diaphragm. Critically, it's protected by the 9th, 10th, 11th, and sometimes 12th ribs on the left side.
So ribs provide protection, but I guess they can also be the source of injury.
Exactly. Blunt trauma to the left lower chest or upper abdomen, the kind that might fracture those ribs, is the most common cause of splenic injury. A broken rib fragment can easily puncture or lacerate the spleen surface.
What about its neighbors? What organs does it bump up against?
It has a smooth, convex outer surface, the diaphragmatic surface, that fits snugly against the underside of the diaphragm. The inner, or visceral surface, is where it contacts other organs. It typically shows impressions from the stomach, gastric area, the left kidney, renal area, and that left colic flexure we just talked about, colic area.
And the hilum, where the vessels go in and out Any crucial relationships there?
Ah, yes, the hilum is vital. This is the entry and exit point for the splenic artery and vein. But the really critical relationship here involves the pancreas. The tail of the pancreas actually extends across the abdomen to reach right into the splenic hilum.
The tail of the pancreas touches the spleen's entry point.
It does. It travels there within a peritoneal fold called the splenorenal ligament. This close proximity is a major surgical hazard. If you have to remove the spleen, a splenectomy, you have to be incredibly careful not to accidentally injure or clamp the tail of the pancreas, which lies right there. Damaging the pancreas could release digestive enzymes,
Causing pancreatitis, a serious complication.
Got it.
And as a lymphatic organ, where does its lymph drain? Does it follow that pancreatic connection?
It does indeed. Lymphatic vessels leave the hilum alongside the splenic vessels and drain first to the pancreaticosplenic lymph nodes. That name tells you everything about the close relationship. From there, the lymph travels onward to the main celiac nodes near the aorta. This pathway is important for tracking the spread of certain cancers.
Okay, spleen covered. Now for the pancreas. You described it as retroperitoneal and centrally located. It seems notoriously difficult anatomically. Where exactly is it and how fixed is it?
The pancreas is definitely complex, both structurally and functionally, with its dual exocrine and endocrine roles. Location-wise, it lies transversely, like a flat tongue, across the posterior abdominal wall, mostly behind the stomach. And yes, it's almost entirely retroperitoneal, except for its tail.
So, very fixed, deep in the abdomen.
Very fixed and very deep, which is why it's generally not palpable on physical exam. This deep location, unfortunately, contributes to pancreatic cancer often being diagnosed late. Its most defining relationship is how its head end is nestled right into the C-shaped curve of the duodenum, the first part of the small intestine. We usually divide it into 4 parts, and understanding what each part relates to is key. There's the head, neck, body, and tail.
Let's start with the head. It's tucked into the duodenum's curve, you said.
Yes, the broad head sits snugly in that C shape. And extending from the lower back part of the head is a little hook-like projection called the uncinate process.
Uncinate process. What's significant about that little hook?
Its location is incredibly significant. The uncinate process hooks behind the major blood vessels supplying the intestines, the superior mesenteric artery and vein, SMA-SMV.
Oh, wait. So the head of the pancreas wraps around the main artery and vein for the gut.
A part of it does, yes. The uncinate process specifically lies posterior to those vessels. This makes surgery in this area incredibly challenging. If you have a tumor in the head of the pancreas, especially the uncinate process, it can very quickly involve or encase these vital vessels.
Making removal impossible or extremely risky.
Often, yes. It's one of the main reasons why pancreatic cancer surgery, like the Whipple procedure, is so complex and carries significant risk. You're operating right at the vascular hub of the abdomen.
Okay, head and uncinate process. What about the neck?
The neck is a short, slightly constricted part connecting the head to the body. And anatomically, the posterior aspect of the neck is another landmark of huge vascular importance.
More vessels.
This is where the hepatic portal vein is formed. The superior mesenteric vein bringing blood from the intestines, and the splenic vein bringing blood from the spleen, stomach, and pancreas itself, join together right behind the neck of the pancreas to create the portal vein, which then carries all that nutrient-rich but oxygen-poor blood to the liver.
So the portal vein literally starts right behind the pancreatic neck.
Literally right there. Which means, again, that inflammation like severe pancreatitis or a tumor in the neck of the pancreas can easily compress or cause a clot, thrombosis, in the portal vein right at its origin.
Leading to portal hypertension and all its downstream consequences.
Precisely. Back pressure into the spleen causing splenomegaly esophageal varices, ascites. It really is the vascular crossroads.
Okay, neck is the portal vein origin, then the body.
The body is the main part, extending across the midline, lying behind the stomach, across the aorta and the left kidney, still retroperitoneal and fixed.
And finally, the tail. We already mentioned this one, reaching the spleen.
Yes, the tail is the only part that's somewhat mobile. It extends to the left and, as we said, enters the splenorenal ligament to reach the hilum of the spleen. That intraperitoneal tail is the exception to the retroperitoneal rule for the pancreas.
The pancreas isn't just a structure. It's delivering potent digestive juices. Let's talk about the duct system. How do those enzymes get into the duodenum, and where does it connect with the bile system? This seems like another critical junction.
Absolutely critical. The main drainage pathway is the main pancreatic duct, or duct of Wirsum. It runs a whole length of the pancreas, from tail to head, collecting enzyme-rich juice from all the little lobules.
Okay, one main pipe running through it.
Pretty much. Now, as this main duct reaches the head of the pancreas, it typically joins forces with the common bile duct, which is carrying bile down from the liver and gallbladder.
They join together before entering the duodenum.
Yes. They usually unite just before, or sometimes as they pass obliquely through, the wall of the second part, the descending part of the duodenum. This combined duct then opens into a slightly dilated common chamber embedded in the duodenal wall called the hepatopancreatic ampulla, or ampulla of Vetter.
Hepatopancreatic.
Yeah.
Liver and pancreas joining up.
Exactly. And the opening of this ampulla into the duodenum itself is a little bump called the major duodenal papilla. There's a muscular sphincter there, the sphincter of Oddi, controlling the release of both bile and pancreatic juice into the intestine.
Wow. So you have bile, essential for fat digestion, and pancreatic enzymes, essential for digesting everything else, all coming out through one tiny shared exit point controlled by a single sphincter.
That's the setup. And you can immediately see the potential for trouble, right?
Absolutely. If anything blocks that ampulla or papilla, like a gallstone that's passed down the bile duct and gotten stuck, or a tumor in the head of the pancreas pressing on it.
It causes a major traffic jam. Blockage there obstructs both systems. Bile backs up, leading to jaundice, yellowing of skin and eyes because bilirubin can't get out. And pancreatic enzymes back up into the pancreas itself.
Which causes the pancreas to start digesting itself.
Essentially, yes. The backed up enzymes can become prematurely activated within the pancreas, leading to inflammation and tissue damage that's acute pancreatitis, which is incredibly painful and can be life-threatening. It's a perfect example of how a tiny anatomical choke point can cause massive multi-system problems.
That really drives home the importance of understanding these connections. Okay, we've laid down the anatomical tracks for the large intestine, spleen, and pancreas. Let's now really focus on the clinical correlations, pulling from those clinical boxes in the text, starting back upstream, slightly esophagus and stomach pathology. Let's talk hiatal hernia.
Right, hiatal hernia. As the name suggests, it involves the hiatus, specifically the esophageal hiatus in the diaphragm, that opening the esophagus passes through to reach the stomach. A hernia here means part of the stomach protrudes upwards through that opening into the chest cavity, the mediastinum.
And this is usually due to weakening of the diaphragm muscles around that opening.
Mostly, yes. It's often seen after middle age, likely due to age-related weakening of the phrenoesophageal ligament and the diaphragmatic crura that normally keep that junction tight and in the abdomen.
The text distinguishes between two main types, paraesophageal and sliding. Why is that distinction important clinically? Do they cause different symptoms?
They do, and the risks are different. The paraesophageal hiatal hernia is less common. Here, the actual junction between the esophagus and the stomach, the cardia, stays in its normal position below the diaphragm, but a part of the stomach, usually the fundus, the top bulge, herniates up alongside the esophagus.
So the valve mechanism at the junction might still work.
Often it does. Because the gastroesophageal junction itself hasn't moved up, the normal anti-reflux mechanisms might be preserved. So patients with a paraesophageal hernia often don't have symptoms of acid reflux or heartburn. The danger here is more mechanical. The herniated pouch of stomach could potentially get trapped, incarcerated, or twist volvulus in the chest, which is a surgical emergency.
Okay, so paraesophageal, less reflux, more risk of strangulation. What about the other type?
The more common type is the sliding hiatal hernia. In this case, the actual gastroesophageal junction, the cardia itself, slides upward through the hiatus into the chest, dragging a portion of the stomach with it.
So the valve itself moves out of position.
Exactly. When the junction moves up, it loses the reinforcement from the diaphragmatic pinch, and the angle becomes less acute. This compromises the lower esophageal sphincter's ability to prevent reflux. So sliding hernias are the ones typically associated with chronic gastroesophageal reflux disease, GERD, heartburn, regurgitation, chest pain.
Makes sense. Moving down to the stomach outlet, the pylorus. We touched on its muscle. Let's discuss pyloric stenosis, especially the congenital kind in babies.
Congenital hypertrophic pyloric stenosis, yes. This is a condition seen in infants, usually within the first few weeks of life. It involves a massive thickening hypertrophy of the circular smooth muscle layer of the pylorus, that muscular valve controlling stomach emptying.
So the muscle gets too thick and blocks the exit.
Precisely. The thickened muscle narrows the pyloric canal so much that milk or formula can barely pass through or can't pass at all. This leads to the classic symptom: forceful projectile vomiting, usually without bile, since the blockage is before the bile duct enters the duodenum.
And the text mentioned it's much more common in boys.
It is, strikingly so. About 1 in 150 male infants versus maybe 1 in 750 female infants. The exact reason for the hypertrophy and the male predominance isn't fully understood.
But it's treatable.
Oh yes, very treatable with surgery. A procedure called pyloromyotomy, specifically Ramstedt's pyloromyotomy, involves making a careful lengthwise cut through the outer thickened muscle layer down to the submucosa, but leaving the inner lining intact. This splits the constricting muscle ring, allowing the pylorus to open up and gastric contents to pass normally. It's usually curative.
Okay. Now, thinking about the stomach body and gastric carcinoma, we know it's serious, but anatomically, why is it so difficult to achieve a surgical cure, especially once it's spread a bit? You mentioned lymphatics earlier.
Yes, the lymphatic drainage of the stomach is incredibly extensive and follows multiple predictable pathways. This is the main challenge. Gastric lymph doesn't just drain to one nearby node group. It can go in several directions simultaneously.
Where does it typically drain?
It drains along all the major arteries supplying the stomach. So lymph flows towards the celiac nodes, the main hub, but also specifically to pancreatico-splenic nodes along the splenic artery behind the stomach, pyloric nodes near the duodenum, nodes along the lesser and greater curvatures. It's a really wide net.
So even a seemingly localized tumor might have already sent microscopic cells quite far through these lymphatic channels.
Exactly. And to have any hope of cure, a cancer surgery needs to remove not just the primary tumor, but also all the potential regional lymph node basins it might have spread to. For the stomach, this often means a very extensive operation.
How extensive? What else might need to come out?
To get adequate lymphatic clearance, surgeons often need to remove not just a large part or all of the stomach, gastrectomy, but also the omentum, the fatty apron attached to the stomach, which is rich in lymphatics, and sometimes even the spleen to clear those pancreatico-splenic nodes effectively. Getting to nodes around the head of the pancreas and the celiac axis is also technically demanding because of all the major blood vessels there.
So the anatomy dictates a really radical approach for potential cure.
It does, and sadly, because early gastric cancer often has vague symptoms, many patients present when the disease has already spread through these extensive lymphatic networks, making a complete surgical cure impossible.
A sobering point. Okay, let's shift back down to the intestinal tract conditions, starting with the absolute classic, appendicitis. We talked about the variable position. Let's nail down that pain progression again. Why does it start vague and central, then become sharp and localized to the right lower quadrant, RLQ?
Right, appendicitis, acute inflammation, usually because the lumen gets blocked. In kids, often it's swollen lymphoid tissue within the appendix wall that causes the blockage. In older adults, it's more commonly a fecalith, a small, hard piece of stool.
So blockage leads to inflammation and swelling.
Yes, and pressure builds up inside the appendix. This stretching and inflammation triggers pain signals. Now, the initial pain is carried by visceral efferent nerve fibers. These fibers travel back to the spinal cord, accompanying the sympathetic nerves.
And where do they enter the spinal cord?
They enter primarily at the T10 spinal cord level. This T10 level corresponds embryologically to the structures derived from the midgut, which includes the appendix, and importantly, it also supplies the skin dermatome around the umbilicus.
So the brain gets a signal from T10, and it interprets that as pain coming from the T10 skin area, the belly button.
Exactly. The brain isn't very good at pinpointing the source of visceral pain. It just knows something is wrong in the T10 territory. So the patient feels this vague, dull, poorly localized ache in the periumbilical region. That's the visceral pain phase.
Okay, vague T10 pain first. How does it become sharp RLQ pain?
As the inflammation worsens, the swollen appendix eventually irritates the adjacent parietal peritoneum. That's the lining of the actual abdominal wall cavity. Unlike the visceral peritoneum on the organ itself, the parietal peritoneum is rich in somatic sensory nerves, the same kind of nerves that supply your skin and muscles, allowing for precise localization.
And the parietal peritoneum in the RLQ is right over the appendix.
Usually, yes. Specifically, it irritates the peritoneum overlying the iliacus and psoas muscles in the right iliac fossa. When that lining gets inflamed, the pain becomes sharp, intense, and very well localized to the RLQ. The patient can usually point to the exact spot with one finger. This is somatic pain.
And that transition from vague umbilical to sharp RLQ pain is the classic diagnostic story.
It's the classic temporal sequence, and it also explains the physical signs. The tenderness at McBurney point is due to pressing on that inflamed parietal peritoneum. And the psoas sign pain when you extend the patient's right hip works because extending the hip stretches the psoas muscle, which pulls on the irritated peritoneum overlying it.
Brilliant anatomical explanation.
Uh.
Okay, moving along the colon, let's talk diverticular disease. What are diverticula and where do they usually pop up?
Diverticulosis is the condition of having diverticula, which are small outpouchings of the colonic mucosa and submucosa that herniate through the muscular wall of the colon. Think of them like little blisters poking outwards.
Herniating through the muscle layer, where does that happen? Are there weak spots?
Yes, they typically occur at specific points of weakness, namely where the nutrient arteries, the viscera, penetrate the circular muscle layer to supply the mucosa. It seems the muscle layer is inherently a bit weaker at these penetration points.
And are they more common in certain parts of the colon?
Overwhelmingly, yes. They are most common in the sigmoid colon. This might be related to the higher pressures generated in the sigmoid to move more solid stool.
So diverticulosis is just having them. When does it become diverticulitis?
Diverticulitis occurs when one or more of these pouches becomes inflamed or infected, usually because a small piece of fecal matter gets trapped inside, obstructing the neck of the diverticulum.
And that inflammation can be dangerous.
Very. The inflamed diverticulum can swell, potentially rupture, or erode into one of those adjacent nutrient arteries that created the weak spot in the first place. Erosion into an artery can cause significant lower GI bleeding. Rupture can lead to a localized abscess or, much worse, generalized peritonitis if stool spills into the abdominal cavity.
And because it's usually sigmoid, the pain is typically left lower quadrant.
Correct. Diverticulitis often presents as LLQ pain, sometimes called left-sided appendicitis because the mechanism is somewhat similar, just on the opposite side.
Okay, that makes sense. Now let's talk about that mobile sigmoid loop again and the risk of volvulus.
Right. Sigmoid volvulus. We established the sigmoid often has a long mesentery, making it very mobile. Volvulus happens when this mobile loop twists around the base of its own mesentery.
It twists on itself, like wringing out a towel.
Exactly like that. It usually twists at least 180 degrees, sometimes 360 or even more. This twisting does two critical things simultaneously. First, it completely obstructs a bowel lumen, causing symptoms of large bowel obstruction, abdominal distension, inability to pass gas, or stool obstipation.
Okay, obstruction. But what's the really urgent problem?
The critical emergency is that the twisting also cuts off the blood supply traveling within that mesentery. Both the arteries supplying the loop and the veins draining it get occluded. This leads to rapid ischemia, lack of oxygen, and potentially necrosis, tissue death, and gangrene of the twisted segment of bowel.
So it's an obstruction and a vascular emergency.
Yes, absolutely. It requires immediate diagnosis, often with imaging showing a characteristic coffee bean sign, and prompts treatment, usually involving untwisting the loop, often via sigmoidoscopy initially, and sometimes surgical resection of the affected segment to prevent recurrence, especially if the bowel looks compromised. It's a true surgical emergency because of that risk of strangulation and perforation.
Okay, really highlights the danger of that mobility. Now, let's turn finally to emergencies involving the spleen and pancreas. We talked about the spleen being fragile. Tell us more about rupture of the spleen.
Despite being tucked under the ribs, the spleen remains the most frequently injured organ in blunt abdominal trauma, things like car accidents, falls, direct blows to the left side.
Why is it so susceptible if it's got rib protection?
It comes down to its internal structure and its capsule. The spleen has a very thin, taut outer capsule. Inside the splenic tissue itself, the pulp is very soft and friable, easily torn. It doesn't have the structural integrity of, say, the liver or kidney, so a sudden increase in intra-abdominal pressure or direct impact can easily fracture the spleen or tear it away from its vascular pedicle at the hilum.
And because it's so vascular.
The consequence is immediate and often catastrophic, profuse intraperitoneal hemorrhage. The spleen bleeds massively when ruptured. Patients can very quickly go into hypovolemic shock. It often requires emergency surgery, splenectomy, or sometimes splenic repair salvage is possible to control the bleeding.
A truly life-threatening injury. Now, the pancreas is much better protected, deep and retroperitoneal, but pancreas rupture can still happen. How?
It takes significant force, usually severe, direct, forceful compression of the upper abdomen. The classic mechanism is a steering wheel injury in a car crash or any trauma that violently crushes the upper abdomen against the solid vertebral column behind it. The vertebrae act like an anvil.
crushing the pancreas between the impact and the spine.
Exactly. The pancreas, being somewhat brittle itself, can literally be fractured or torn by this crushing force. The biggest danger here isn't usually immediate hemorrhage, though that can occur, but rather the tearing of the pancreatic ducts.
Ah, releasing those digestive enzymes we talked about.
Precisely. When the ducts are torn, potent pancreatic juice leaks out into the retroperitoneal space and potentially into the peritoneal cavity. These enzymes immediately begin to autodigest surrounding fats and tissues.
Causing intense inflammation and pain.
Intense agonizing pain, often radiating to the back. It leads to severe chemical peritonitis and pancreatitis. It's a devastating injury because of that enzymatic destruction.
And related to that destructive potential, let's talk pancreatic cancer. Why is it often diagnosed late, and why is the prognosis often so poor, relating back to the anatomy?
Pancreatic cancer, particularly adenocarcinoma arising in the head of the pancreas, the most common site, is notoriously insidious. Early symptoms are often vague weight loss, maybe some non-specific abdominal discomfort, perhaps jaundice if the bile duct gets blocked early. But because the pancreas is so deep and retroperitoneal, tumors can grow quite large before causing really obvious symptoms or being palpable.
So late diagnosis is common, and when it is diagnosed, what anatomical factors make treatment difficult?
Several factors. We already discussed the proximity of the head uncinate process to the vital SMA-SMV vessels, often leading to vascular invasion that precludes surgery. Additionally, the pancreas sits right in front of major nerve plexuses on the posterior abdominal wall, like the celiac plexus. Advanced cancer frequently invades these nerves posteriorly, which is a major cause of the severe, unrelenting back pain often seen in late-stage pancreatic cancer.
Nerve invasion causing that characteristic pain.
Yes. And surgically, even if the vessels aren't involved, removing the head of the pancreas is inherently complex due to its shared connections. As we discussed, the head is intimately fused with the duodenal loop, they share blood supply, and the common bile duct passes right through it.
So you can't just take out the pancreatic head alone.
Almost never. A standard pancreatic duodenectomy, Whipple procedure, requires removing the head of the pancreas, the entire duodenum, the first part of the jejunum, the gallbladder, the distal common bile duct, and often the distal part of the stomach. It's a massive resection and reconstruction, reflecting those intimate anatomical relationships. The complexity contributes to the high morbidity and mortality associated with the disease.
It really underscores how central the pancreas is. One last clinical point. The connection between central venous pressure and organ size, specifically hepatomegaly and splenomegaly. How does something like heart failure cause the liver and spleen to enlarge?
This relates directly to the venous drainage pathways and the lack of valves in the major veins involved. The inferior vena cava, IVC, which receives blood from the lower body and the liver via the hepatic veins, doesn't really have effective valves. The hepatic veins themselves lack valves.
So blood can flow backwards easily if pressure builds up.
Yes. If you have a situation causing high pressure in the right side of the heart, like severe right-sided congestive heart failure, that increased pressure gets transmitted backwards, up the IVC, and directly into the hepatic veins and liver sinusoids.
Forcing the liver to swell up with blood.
Exactly. The liver becomes engorged with blood, causing it to enlarge. That's hepatomegaly. This stretching of the liver's outer capsule, Glisson's capsule, which is richly innervated, causes right upper quadrant pain and tenderness.
And how does the spleen get involved? Does the pressure back up through the portal vein?
It does, indirectly. The increased pressure in the liver sinusoids impedes outflow from the portal vein, which normally drains into the sinusoids. This backup raises pressure throughout the entire portal venous system, including the splenic vein. The spleen, being a spongy vascular organ, also becomes congested with blood and enlarges splenomegaly. So systemic venous congestion rapidly leads to painful enlargement of both organs due to these direct vascular connections.
A really clear link between cardiovascular mechanics and abdominal organ pathology.
Fantastic. Well, that was definitely a comprehensive deep dive. We've covered the unique features of the large intestine, the tinea haustra, appendages, and mapped its course, noting which parts are fixed and which are dangerously mobile. We've also navigated the complex retroperitoneal anatomy of the spleen, and especially the pancreas, highlighting those critical vascular and ductal relationships at the abdominal crossroads. And hopefully we've clearly linked that anatomy to the why behind common clinical problems, from the migrating pain of appendicitis, explained by visceral versus somatic innervation, to the devastating consequences of volvulus, rupture, or cancer invading these tightly packed structures.
Absolutely. So we've essentially completed our tour of the main GI tract organs within the abdomen proper. Next time, we're tackling a giant, the liver.
Indeed. The next deep dive will focus entirely on the liver. We'll explore its role as the body's largest gland, look at its complex internal segmentation, understand its fascinating dual blood supply, the hepatic artery bringing oxygen, and the portal vein bringing nutrient-rich blood from the entire gut. We'll also cover the gallbladder and the biliary duct system.
The portal system sounds particularly crucial.
Oh, it's absolutely vital. Understanding portal venous flow and pressure is key to understanding major liver diseases like cirrhosis and portal hypertension. We'll spend significant time on that.
Sounds like another essential session. Before we wrap up, though, a final thought for our listeners to ponder, connecting back to today's discussion.
Let's revisit that vascular watershed area. We established the large intestine has that dual supply from the SMA and IMA, meeting near the left colic flexure, and that this juncture can be relatively poorly perfuse the watershed.
Right, the anatomical weak link.
Now, really picture that patient in profound shock. Maybe massive trauma, sepsis, severe dehydration. Their overall blood pressure plummets. The body tries to shunt blood to vital organs like the brain and heart. Where does that leave the gut, especially that watershed area?
It's probably getting critically low flow.
Exactly. That specific segment at the splenic flexure is often the very first part of a bowel to suffer irreversible ischemic damage and prolonged shock states. It's a direct, predictable consequence of its anatomical position at the fragile boundary between two major arterial territories. It highlights how embryology and vascular anatomy create inherent vulnerabilities that manifest dramatically in critical illness, something to keep in mind when managing those severely ill patients.
A powerful reminder of anatomy's immediate clinical relevance. Think on that connection between structure and critical risk. Thanks, everyone, for listening to Bookfulness.
We'll see you next time for our deep dive into the liver.